There's no health without heart health. You can be rich, poor, tall, short, old or young, it really doesn't matter. If your heart checks out, you go with it. Next, we're going to hear from the man who has built his career and his company around the need to keep your ticker ticking. Please welcome, in conversation with Paul Nuki from the Daily Telegraph, co-founder of one of health tech's newest unicorns, Charles Taylor.
Hey, Charles, come up here, yeah. Well, thanks very much. I know a little bit about Charles's company because I spent some time having an egg and bacon breakfast with him in order to get my heart done. It is the most fantastic business, brilliant innovation, and saving a lot of lives. And perhaps the best thing about an AI product, from my point of view, is normally you have to ask people, what problem is your business trying to solve? But I can ask you, what problem is your business, your AI business, actually solving now?
We're actually using AI to improve the diagnosis of patients with coronary artery disease. So we're using that to help physicians interpret information coming from diagnostic imaging and providing information about that they use in deciding whether to treat a patient with medicine, with stents, or surgery.
Yeah, because when we all age, like I am, so guys and women, heart attack is pretty common, right?
Yeah,
it's
it contributes to a third of all global deaths. It's a leading killer worldwide. It's incredibly common, and of people, especially over a certain age. By the time you cross the 50 years of age boundary, then it becomes much more common.
And just to help people get it in context, I guess people think of it as a male problem, but I think it kills a lot of women too.
Yeah, actually, more women die of heart disease and disease in their coronary arteries than die of breast cancer. So, the leading cause of death for men as well as women.
And just tell us a little bit about the process. So I go into the doctor, I've got some chest pains.
Yeah.
I go through a process. Which bit of the process is your business chopping out?
Yeah. So I think it helps, first of all, take a step back and explain what is heart disease, why do people die of heart disease. So I think all of us don't think much about that, but of course the heart is a muscle, it needs a blood supply. The heart gets its flow from vessels that wrap around the outside and then penetrate into the muscle of the heart. These are called the coronary arteries. If these coronary arteries have disease in them, plaques or atherosclerosis in them, this plaque can cause the patient to experience symptoms, or the plaque can rupture and cause a heart attack, maybe survivable, often fatal. So it's a disease in those coronary arteries which is the primary reason why people have heart attacks. Now, if a patient goes to the doctor and they say they're complaining of chest pain, or they have some symptoms of family history, and they're trying to sort this out, then the physician's going to do a whole range of tests for them. They're going to, of course, ask them about their family history, try to understand what other risk factors they have. But depending upon the risk that the patient is presenting with, the physician will often do a test. Typically starting with a non-invasive test. For example, an imaging test to look at whether there's a limitation of blood supply to the muscle of the heart, maybe an exercise test or something like that. The fundamental problem, though, with those tests today is it's really remarkable, is that just the tests don't provide very accurate diagnoses. There was a study done in the US a couple of years ago, and based upon, first of all, this is in hundreds of thousands of patients who had a positive test. They went to a catheterization lab, and the cardiologist expecting to treat the disease maybe with a stent, and more than half of those patients with a positive non-invasive test didn't have disease in the coronaries.
So I think it's overall, when you go for when your doctor's worried you've got a heart condition, they do an invasive test.
Yeah.
There's some risk attached to it.
That's right.
a considerable cost. And I think
right.
you're saying that 75% of all those tests, it turns out there's
To be negative. Yeah,
To be negative.
not have anatomically significant disease or disease that's limiting the blood supply to the muscle of the heart. So that's really staggering. So you go into different healthcare systems and you have a lot of people in the queue, that are on their way into that invasive test, based upon other non-invasive tests they've received. And a small minority of them will actually need to be there and to get treated. But it ends up in UK, for example, with often long queues, with people waiting with symptoms of chest pain. So the patients who really need to get in there and get treated are waiting in the queue with a lot of other patients that, quite frankly, should just go off and be treated with medicine, lifestyle changes. So that's the conundrum right now today. And this is kind of the space that we entered when we brought our technology to bear on this problem.
So that's the problem you guys are solving is that invasive testing and its poor results. Tell us a little bit about how your AI does that. Tell us a little bit about where it came from.
Yeah.
I believe the armaments, or at least the airline industry.
Yeah.
And I think you can show us a demo as well. About how the technology images to produce its results.
Yeah. So our technology at Heartflow is based upon, it starts with a CT scan of a patient's heart, where the anatomy data is extracted or the imaging data is there. Now the tricky part is actually pulling information about the coronary arteries out of these exams, out of these CT scans, because there's a lot of disease, the heart's moving, the data doesn't look great. So our AI basically now, which has been trained on thousands and thousands of patients, basically does the recognition, pattern recognition, what's called computer vision, to extract the anatomy of the coronary arteries. And it does it extremely accurately and precisely. That once the anatomy is extracted, we actually then simulate, using computational methods, simulate blood flow in their arteries and actually predict whether the disease is limiting the blood supply to the muscle of the heart. So if we could actually show a video, maybe now would be a good time to show that.
Yeah, that would be great. Here we go.
So this is going to show the coronary arteries, and the big, thick section is the root of the aorta. We see the coronary arteries again wrapping around where the heart would be. The areas of red have a score. There's 6.65. That means in that location in the artery, the blood supply is 65% of what it really should be. It's low. In that area where it goes from red to blue is the area where it would, a patient would often, based upon our test, receive a stent. So we provide this information, a complete picture of the coronary arteries. The physicians look at it, and then they act based upon that, and they use that information to manage the care of their patients.
So there's two things which I think are amazing about that visualization. So it's a precise visualization of the patient's heart, which is amazing in of itself. But the real skill of the AI is that it's measuring the pressure through those veins, which negates the need for the surgeon to get in there and do something invasive to test that pressure.
So for example, what physicians will often do in the catheterization lab, they'll put a wire into the coronary arteries downstream of that disease. Now, sticking a metal wire into the coronary arteries, you could imagine, is something, first of all, it requires an invasive procedure. You have to puncture an artery in your groin or your wrist, get a catheter up there and measure pressures. So it's really an invasive procedure. It's an invasive diagnostic test. And as we were saying, most of the time when that test is done, it's negative. So if we could better identify those patients that really just don't go on, don't need to go on and get that invasive test, then it's better for patients. The other aspect of this invasive test is it's expensive. So we've done studies in every healthcare system we've looked at, whether it's the UK, it's Europe, it's US, it's in Asia. Eliminating these tests with invasive tests which are ultimately unnecessary saves a lot of money. In the US, thousands of dollars per patient. There's millions of these patients per year, so billions of dollars in healthcare savings with a better result, a better clinical result for the patient.
And Charles, just the idea and the science behind
Yeah.
measuring blood flow.
Yeah.
Tell the audience where it comes from. So.
Yeah, so it actually came about. I started working on this problem about maybe 23 years ago or so, on that order. As a graduate student at Stanford, I was doing my PhD, and I was actually doing work funded by the U.S. Air Force to look at computing flow over airplanes, and happened to see a new surgeon that came into Stanford that just started the vascular surgery division, and was really interested in collaborating with engineers to understand not airflow but blood flow in the body and the arteries. I by pure chance, I went to see a talk that he gave, and the next day I had completely changed the course of my career and my PhD and everything else. So after I finished my doctorate, I'm an engineer, trained as an engineer, but I joined the faculty in the medical school, and actually in the Department of Surgery. You know, the funny part about that is whenever we'd have faculty photos, they made me put on a white coat, so I didn't stand out too much. But, you know, an engineer in the medical school, there hadn't been somebody appointed at Stanford in the medical school that was not a physician. So I worked over the years, you know, over about, you know, I was spent 14 years on the faculty at Stanford in surgery and in bioengineering departments, and kind of built out the technology. In a sabbatical 10 years ago, I started thinking about what I wanted to do with the rest of my life, and started to contemplate this idea. It was just kind of this eureka moment where I saw what was happening in cardiology, and I knew that I didn't know whether we could do it or not, but I knew that if we could, it would have a big impact. I recognized 10 years ago it would save billions of dollars in healthcare costs.
Okay, so from the pressure lines on airliners, you're taking it to the heart, but these businesses are much more than an idea. They take a lot of going, and what I think is impressive about Heartflow is that it's an academic juggernaut. So I believe the business has published something in the realms of 250 academic papers, or papers have been published about it.
Yeah.
And so I think a lot of the audience, especially if they're running startups and other businesses, they look at all this peer publishing that you have to do in the medical world and think, God, you know, we can't afford it. It takes too long. But your company, I think it's true to say, really owes its valuation now and its rollout now to getting that work done originally. Is that right?
Based on the science and the evidence. I mean, you can't expect a cardiology to change their clinical practice if there's no evidence that the technology you're introducing to them works. So those papers, and again, it is over 250 peer-reviewed papers in the medical journals. They're not written by us. You know, I've written still a few on the science, but it's almost all the people who are using the test, who are doing clinical trials and evaluating it, and that's critical. It's really important to be able to generate that level of evidence. You know, when I interact with cardiologists, I tell them, try it. You know, see if it works. Here's the evidence, but try it in your own practice. If it doesn't work, don't use it. You know, you need to do the right thing for your patients. Use the best available test. You know, fortunately for us, you know, as we've, you know, generated levels of evidence, we have demonstrated, you know, a very high performance and accuracy against those invasive tests. And we've also been able to demonstrate it you know, basically cuts out about, you know, more than half of those invasive procedures and saves money. So it's about the evidence.
I think one of the pivotal decisions there was made by NICE, which is the body in the UK that, as I understand it, they basically they judge a product or a drug by its financial return. You know, so is it going to provide a real saving for the health service in the UK? And I think your product, Heartflow, went through that process.
Well, actually, first and foremost, it judges it whether it's safe and effective. That's the first question. And then they judge it based upon what will be the financial impact to the healthcare system. And I've got to say, we've had a lot of tech assessments done by in different parts of the world. And I think actually the one in the UK, the NICE, is probably without question the most rigorous. tech assessment process. They took our technology and evaluated all the evidence. It took them about 2 years to be able to come up with a recommendation, and it was very favorable. That then, about a year after that came out, led to funding and support in NHS hospitals to be able to actually introduce it. So, from May of this year, when we had funding available, now we're at 30 hospitals in NHS England,
which is amazing. I mean,
which
anyone
is
out
fast.
there, any of these guys out there who've tried to get products into the NHS will know how difficult it is. So 30 how many hospitals?
30 in the NHS, but also that then triggered the reviews in the US. So it's just, basically all private insurance companies, and also Medicare pays for it in the US. And hopefully we'll have, it's being evaluated right now in Japan as well. So we're starting to roll out in Europe and also in many other parts of the world right now to make this available.
So it's not just AI that's in a clinical setting working at the moment, but it's AI that's rolling out right across the world. US, UK, and hopefully soon Japan.
Yeah. The neat thing, I mean, there's a lot of discussion about AI in healthcare, and there's a misconception you can just take a lot of data, dump it into a computer, and out will come the results. But you actually have to teach an algorithm, quite frankly, how to read data. And in our business model, we have data coming in from any hospital. We install software on the clinical site that lets them securely push the data through the firewall up to our application that runs on Amazon Web Services. Then we apply the deep learning methods, we apply the AI, but then we have people that look at the result of the computer model in the context of the image data and inspect and correct it. So once you do that, you actually get the best of human intelligence and computer intelligence working together synergistically. So once you've done that and corrected a data set, you can actually teach the computer to read, as good as a person. You can actually then exceed human performance by giving it other information, about a group of patients, which is really exciting. I mean, the challenge in imaging and looking at interpreting image data is there's so much information that comes out of a scanner that a person, an individual, cannot look at all that information, cannot do a full assessment of that disease. So it really requires the aid of a computer. We're not replacing doctors, but we're giving them tools that help them be much more efficient and also be synthesizers of information rather than just kind of reading, doing the manual work of reading data.
Okay, and from my point of view, somebody who cares a lot about the NHS, I believe there are projections showing how much money it saves for the NHS, or is likely to save once it's rolled out in full. Is that right?
Yeah, it wasn't our projection, it was NHS's projection. You can find that on the NHS website. They have an estimation in their nice recommendation. They were estimating on the order of £9 million per year of savings. I think that's just based upon reduction of cardiac catheterization. Hopefully it'll be much more than that. But that was their estimation. And the U.S. healthcare system, the estimations are in the billions of dollars of healthcare savings. And
the very last question, Charles, is the valuation of the company. I know I've talked to Charles a little bit, and it is not his main thing, but I think you guys should know.
Yeah. Well, it's public information. The last report was $1.5 billion of valuation. That was before we had Medicare, NHS payment, et cetera. But that's the last information that's publicly available anyways.
So it's a genuine unicorn, and it's really doing great things for people's health today. So thank you very much indeed.
Yeah, thank you.
Thank you.
Thank you.